I believe that there is nothing more important than providing the outstanding members of our military, their families, and our retirees with world-class health care delivered in world-class medical facilities. There is no question in my mind that they deserve nothing less. As the grateful father of 4 sons in the military today, our family has experienced the quality service with 2 grandsons born at Bethesda National Naval Medical Center and a granddaughter born at Portsmouth Naval Hospital. With that being said, I understand that there are a number of military treatment facilities that are 30 or more years old. In the district I represent in South Carolina, Moncrief Army Community Hospital at Fort Jackson was built in 1972, and the Navy Hospital at Beaufort was built in 1947. I know that the outstanding medical personnel in each of these facilities provide excellent care to our troops and their family. On personal tours of each facility, I have been very impressed by the dedicated and competent professional personnel I have met. I also know that as a medical facility gets older, it is more challenging to keep up with the advances in medicine. As I prepared for the hearing today, I was reminded that the planning process for military medical construction is very different than that for other types of construction within the Department of Defense. I'm interested to hear from our panel why medical construction is unique within the department. To that end, today I hope to hear from our witnesses how the department and the military services plan to spend medical construction dollars to either replace or modernize our military hospitals. The members of our armed forces deserve the best. With that, I would like to thank our witnesses for participating in the hearing today. I look forward to your testimony. Thank you, Chairman Ortiz, and I want to join you and my colleagues for the opportunity that we had to meet with Admiral Madison and his staff. It was really exciting to me, just as it was for you, to see the dedicated staff. They were so interested in the wounded warriors, each one. They were so proud of the progress that they were making. It just made you feel so good to see the extraordinary planning and thoughtfulness put into the individual care given to each one of these young people who make such a difference for our country. Additionally, for each of the Surgeon Generals, I think you should be, I want to thank you for making military medicine some of the most advanced in the world. It's looked to around the world as leading the efforts in terms of prosthetics, in terms of trauma care, in terms of preventive virtual medicine, on and on. I wish the American people knew of how extraordinary military medicine is, and the challenge that you have. And for each of the Surgeon Generals, and you've touched on this, but all of you have hospitals and military facilities that would be considered old by any standard. How do each of you prioritize the facilities that you submit to the Military Health System MILCON prioritization process? And what are your top priorities for medical MILCON for the next 5 years? And Admiral, I had the opportunity to fly over. I didn't actually visit the Naval Hospital last month at Guam, but I'm very happy as the Marines are being relocated there to hear that is proceeding.
Yes, sir. Thank you very much for the opportunity. Guam is proceeding. I think that Guam represents the overseas OCONUS facility that doesn't necessarily have the constituency, does not necessarily have the TRICARE network in downtown that can take care. Not suggesting a network doesn't exist, but it doesn't have the robust network that a CONUS facility may have. So the point is that the educational development instructional programs, the exceptional family member programs, the programs that are related to specialty care with the network, all of those programs may be at a either lesser condition or may not exist OCONUS, which then makes those facilities a top priority from a Navy medicine perspective, because I have to make sure that the men and women and families there are cared for appropriately in that particular geographic location. I also think related to the question of network care and going downtown. Network care and access standards are always going to drive how we do business, and they should. At the same time, the reasons that patients often don't want to go downtown is that, or we send them downtown, is that they don't want to go down. They would rather stay with us. With that said, we will never degrade care or get into a quality issue with the patient related to an access standard. I would suggest that if we could re-look at network and how we run military networks within a geographic area and give more responsibility to local commanders with the network, that there could be a more seamless and effective method of how we would actually run our patients and the network, both from the direct and the purchase care side, so that we could have a better and a much easier system of care, and I think the continuity and the quality would follow.
Thank you.
Mr. Wilson, I appreciate your question because it helps me put things in context for the committee. As I mentioned, a significant amount of our medical facilities were built within 15 years after the Air Force was established. The Air Force is positioned across the United States, generally in small communities, and many of our medical facilities were in fact small hospitals. But we very appropriately followed the U.S. medical model, and we closed those small hospitals in favor of ambulatory clinics because they didn't have the critical mass, they were costly, and frankly they were not safe. They didn't have the caseload and complexity to maintain the currency that the staff would require. So we followed that model, and we have a significant number of ambulatory facilities which really are in old inpatient chassis which have been modified over the years. So those do in fact create a concern. Now I will tell you that we do have 15 hospitals, and we have leveraged our O&M dollars as well as our MILCON to maintain those platforms, although several of those come up on the priority list that you asked about. And two primary ones would be the Wilford Hall Medical Center, which under BRAC becomes a large ambulatory surgical center, as does the Andrews Hospital become an ambulatory surgical center. So from an aging infrastructure standpoint, they need to be replaced, and from an alignment with BRAC to assure that they are viable parts of that BRAC outcome, they need to be replaced. So that is in fact driving our prioritization as we work through this process, along with other facilities in the 2010-2011 window. But that is where we find ourselves with aging facilities, but also the need to align appropriately with other activities with our sister services in BRAC.
Sir, we'd use a model of prioritization that's based upon three principal factors: what the current condition of the hospital or the facility is, and how much it's going to cost to repair that. Obviously, the more that's going wrong within a facility that we can't get back to a safe and high standard, then the more impetus to replace it. We look at the population that's supported by that facility and what its capacity is to take care of that population, to include the population that's moving. I think you all are aware that the Army right now is going through four simultaneous kind of word salads: global defense posture realignment, grow the force or grow the Army, Army modularity, and base realignment and closure. GDPR, GTA, AMF, and BRAC are moving about 250,000 people right now, the largest movement of soldiers and their families across communities in a generation. And so we're also looking at projected populations served by those facilities. Last thing I'll make a comment about is General Radebush says, although we tend to be sort of hospital-centric in our thinking, we're comprehensive in building facilities that attend to the health requirements and dental requirements and preventive medicine requirements and veterinary public health requirements of that community, and I don't think we want to lose track of that.
Thank you very much, and in the interest of time, I'll submit further questions because we have votes.